Well, good morning, everyone, and welcome to day 2 of the 2021 Michigan Rural Health Conference, Moving Forward Together. We certainly miss seeing all of you in person, but it's wonderful to see both new and familiar names in our attendee list. All of our conference materials and information can be found on the conference section of the MCRH website. This includes details on our conference partners who make this event possible. Just a couple of quick reminders before we begin. Your microphone and telephones will pick up a lot of background sounds. Please be courteous and keep your microphone muted when you're not speaking during our conference. Please be aware that all sessions and chat questions will be recorded for future work. We appreciate your cooperation in keeping the meeting information and professional. For general Zoom questions and tech help, please connect with our conference help desk via email at lantyv, LANTZYV @msu.edu. For continuing education, we are offering CE credits for physicians, nursing professionals, and social workers. In order to collect your CEUs, please type your name into the chat box during each session you attend. At the end of each day, you'll receive a conference evaluation. Certificates will be processed following the conference. With all of that, I am very pleased to kick off the day welcoming Brian Bauer of Hall Render, Killian, Heath, and Lyman to provide our health law update. You can find Brian's speaker bio and additional session details on the conference section of our website. If you have any questions, please utilize the chat box feature and we'll facilitate any unanswered questions at the end. Brian, you should be able to share your screen now.
All right, well, thank you. Let's see if we work this magic. Are you seeing my slides?
We are.
Super. Well, good morning, everyone. It's nice to see everyone, at least in the virtual sense. I do look forward to the time when we'll be able to get together in person. If I'm understanding correctly, the fall conference at Traverse City is going to be in person. Look forward to seeing you all. Do have a number of things to cover. It seems like it's been forever since we did our last one last fall, and there's been a lot happening. And I think there's some of this that gets missed because of all the COVID and all the emphasis on COVID and what the current status is there. Certainly, all of that is important, but there's a number of other legal issues that have been kind of going on that I think are very important, very interesting. And I probably used this before, but it sticks with me. A number of years ago, Dwight Gasho, I had one of these meetings just before I'm going up. It's like, well, Brian, you got any good news for us today? I'm happy to say that most of it is good news, I think. And so some of it's a little futuristic, some of it's a little detailed, but I really make an effort to pick out the issues that I think that are, the most important and the ones that maybe people don't otherwise get as much information on. So now my slides, are my slides advancing, Sarah?
No, they're not. We're still on your first slide.
Well, all our previous work, let's try this. There we go. Is it advancing now?
It is.
Super, thank you. All right, so the three things that I want to touch on today are a new type of hospital. Actually, probably the more correct term in one respect is a new type of Medicare provider. Because technically to be a hospital, you have to be licensed in your state. And at least in Michigan at this point, there is no official licensure as a rural emergency hospital, but we'll talk about that more in a minute. 340B update. If you listened to Brock yesterday, he touched on this briefly. I want to give you a little bit more information. And then Stark update. Over the years, a number of you, I always think of Scott Pillion in particular, have really been pushing for some updates and changes to the Stark law. And we actually got a number of favorable changes I think it was actually December that the final rule became effective. But I think a lot of that sort of what would be in a normal year normal sort of stuff that gets paid attention, maybe didn't get as much attention as it should. So I want to make sure that we hit those. So Consolidated Appropriations Act of 2021. So actually, this happened December of 2020 as well. But it created a new Medicare provider type called Rural Emergency Hospitals, or REHs. I'm not sure what we're going to do with that acronym. CAHs always got shortened to CAS. I'm not sure what we can do with REHs, but it's a new model, and it's based on, we've seen bills pending with this model or a similar model for a number of years. Grassley and some of the other more rural Midwestern states have been pushing for a type of provider along this line. This is fairly consistent with what the National Rural Health Association, Brock and his folks have been doing. And so I think it's great. We actually got this. It was kind of a surprise. I mean, again, there's been bills over the years submitted that have never moved out of conference. Now we have it. That's a good and bad thing in some ways. I'm glad we have it. I think there's some language in the statute that could have been better, and we'll talk about that more in a minute as well. Critical access hospitals and small rural hospitals can convert to this new provider status and receive new enhanced payments or qualify for enhanced payments starting January 1, 2023. So we're still a ways out, and that's good because, you know, if it's like the critical access hospital program, you had a pilot program that led to the critical access hospital program, but the critical access hospital program didn't get a lot of attention from a lot of rural hospitals for a long time. And, you know, over the years, I've talked to a number of people. I mean, this is really dating me and going back. For those of you who remember Pat Miller, talking to Pat Miller at one time about converting to CAH, and he's like, no, I don't want to do that. I give up my beds. I'll never get them back. You know, and then a year or two later, Pat came back and said, yeah, I think this is the best way to go. So I think we'll have that same sort of process for these new hospitals. It's interesting. I mean, Brock talked about this a little bit yesterday and talked about some of the analysis that's being done by the NRHA and its partners, and the idea that there's a number of hospitals across the state. I think, if I'm remembering correctly, it was 60 some hospitals across the state or across the country that would maybe, you know, more than eligible, maybe interested in this. And I think, if I remember correctly, the criteria that was used was 4 or less inpatient admissions plus an annual budget of 10 million or less. Now, I think that's a good metric, because I don't want to sound like I'm disagreeing with Brock, because I'm not. But I think there's an entirely different sort of group of hospitals this might make sense for. And I think I think the criteria of few inpatient admissions is the key, but I think the more suburban of the critical access hospitals in Michigan, or at least some of them, might find this worthwhile. They're closer to tertiary hospitals generally. They generally have fewer inpatient admissions. So I think there's a number that might be interested in this as well. Again, that's part of the reason that I wanted to have this conversation. So this new status is going to be available to critical access hospitals of and PPS hospitals of 50 beds or less. So you're going to be able to make that transition. Now, the statute does say that it has to be licensed as a rural emergency hospital under state law. I'm not sure if there's any of the states that actually have a category for a rural emergency hospital. Michigan does not. And technically under Michigan law, to be licensed as a hospital, you have to have the ability to do inpatient admissions and overnight stays. Well, this would provide for an overnight stay, but not for inpatient admissions. So I think once we get into this, if this starts to get some momentum, we're going to either need to get some clarification from Lara, or we're going to need to get some legislation. I know the center has reached out to Lara and made them aware of the new legislation and the opportunity. But right now, under Michigan law, we really don't have the ability to take that step. When I say either some clarification from Lara or some new legislation, again, the statute in Michigan says to be a hospital, you need to be able to do inpatient admissions. Now, from time to time, I know Lara has let some hospitals go for a period of time when they maybe didn't have any inpatient admissions. But the key was that there always was a point when they were doing it, and they eventually got back, so far as I know, to doing inpatient admissions. So this requirement, being licensed under state law, will need some attention if there's any hospitals, again, critical access or PPS hospitals under 50 beds that actually want to move forward with this. The next criteria is must provide emergency department and observation services. So that's the real focus of this of this type of provider, is to provide emergency services in rural areas, observation services, overnight stays, but no inpatient services. Now, as we get down to the last two bullet points on this slide, you start to see some what I think of is different ways CMS is viewing things based on what they've learned through the Medicare Shared Savings Program. They're not specifically saying these types of outpatient services are permitted or these are not going to be permitted. What they're going to address that is in two ways. One, through CMS rulemaking, because as you know, the statute gives us the basic framework, but all the details really come through the CMS rulemaking process. So I think we're going to see some of that, some limitations put on that, but I wouldn't be surprised if that is fairly broad in what the outpatient services are going to be permitted. But, and we'll talk about this in a second here, but there's an application process. I think CMS has gotten real comfortable with this whole application process concept through the Medicare Shared Savings Program. And so there's, I think the outpatient services in the statute are saying you're going to be able to provide them, but it doesn't say which ones, if there's any limits or boundaries on that, any exclusions. Some of that we're going to get through the CMS rulemaking process. Some of that I think we're going to see through an application process where our CMS says, all right, tell us about what you want to do, what you've done before, and we'll then decide what we approve. I think it is important that the statute does permit hospitals, any of our hospitals now that have a SNF, to continue operating that SNF. Any of our hospitals now that operate ambulance services are going to be able to continue to do that. So those are specific services that we know that we're going to be able to continue. So what is this entity going to need to do? Well, they're going to need to staff an emergency department 24/7. And I would expect it to be very similar to the critical access hospital conditions of participation for emergency services. I think it's going to be basically the same thing. There may be some differences just simply because it is an emergency hospital. For those of you who, I'm not sure any of our hospitals do this in the state, but certainly in some more rural Western states, you don't have a physician NP or a nurse specialist PA actually in-house 24/7. You have some of them on call, I actually in South Dakota at one point had a need to go to the emergency department, and they had a physician on call. I had to wait to come in, got to be there within 30 minutes. So it may be that same sort of flexibility, or it may specifically require actually having the practitioner in-house 24/7. I think most of our hospitals already do that, so I'm not sure that'll be a change or anything we really need to spend much time thinking about. Again, that'll be covered in the rulemaking process. Enter into a transfer agreement with a level 1 or level 2 trauma center. We already have transfer agreements generally. The statute talks in terms of a transfer agreement, but I don't think there'll be any limitation on you have to pick one. I think it'll be able to have a number of facilities, and we probably want a number of facilities that we have the ability to transfer to. The next one, and I don't know exactly how I feel on this next one, maintain an annual per patient average of 24 hours or less. Now, we do have the ability, and specifically the statute provides for observation services. So it's not going to be unusual to keep somebody overnight for observation services. I personally think it probably would have been better to stick with the 36 hours that we have under the critical access hospital program. But in this case, I think the concept is it's supposed to be a sophisticated rural emergency room or emergency department. Generally, if you need somebody to be admitted, well, then you need to get them out, get them on an ambulance, and get them out to another facility for admission, or if they're fine, then obviously they're doing discharge. EMTALA is going to be interesting with this because I would expect some changes to the regulations there, just to address the specifics of this, because there are going to be some nuances for this new provider type that aren't going to fit within the normal EMTALA concept of, this is a hospital with an emergency department. This is a little different. We don't have the ability to admit a patient. So I think we're gonna see a little tweaking there. The last bullet point on this page is, I think, again, something that we're seeing as a consequence of CMS's experience with the Medicare Shared Savings Program, comply with quality reporting standards as determined by CMS. So, I mean, to a certain degree, we all have quality reporting standards, but I think this is we're probably going to see something a little bit more unique here. Again, probably in connection with that whole application process. But this is a little bit of a different wrinkle, I think, connected with this new organization. So if you're interested in doing this, we're going to need to submit an application. And that includes an action plan for initiating the services, how the facility plans to change its services. So what do we do now? What are we going to do as an REH? And how are we going to transition to that new status? Planned non-emergency outpatient services. Again, I think there's going to be a part of the application that says, what services do you provide? Probably, what services are you currently providing? What services do you want to provide? What's the transition? Why are you dropping some? Why would you be adding some? That sort of thing. I think it's going to be interesting. Excuse me. I think it's going to be interesting to see what this application looks like. And I think we're going to get a message from CMS pretty early on how they view these new entities, whether they support them, or just because they're in the legislation, they got to do it. Maybe they're not as supportive. Because, excuse me, because and I've seen this in the MSSP and other CMMI programs, if CMS wants people in the program, they're very supportive, very Yeah, that's good. Well, that'll work. And if they have a problem, helping you work through it. But if they get to the point where they want to regulate the number of groups or hospitals, facilities converting, then the application process becomes more stringent. And I don't want to say more restrictive, but it's more like, well, we think this, go back and fix it. You can reapply next year, sort of an attitude. So we're going to, I think through this application process, we're going to get some indication of how CMS feels about the program. Facilities got to tell how or explain how they're going to use the REH facility payments. And there's really two payment methodologies, or two parts to the payment methodology. The first is we're going to get paid under the outpatient prospective payment system, the OPPS, which is going to be basically in a lot of ways new for us, moving off that cost-based reimbursement. We're going to get a bump. We're going to get 105% of the out-based prospective payment system. And so that's what we're going to get when we submit our claims. In addition to that, we're going to receive a monthly facility payment, which is, I'm not sure why CMS had to be this obvious, but 1/12 of the average of the annual benefit. It's interesting how they've come up with it, their method. In some ways, I appreciate the simplicity, because, you know, keep it simple is always a good thing. But in some ways, I don't know that this facility payment methodology is really going to be, I think there's going to be some winners and some losers, because basically what CMS is proposing, or what the statute calls for, to be more precise, is that all the payments to all CAHs in 2019, what they're basically going to say is, well, in 2019, all the critical access hospital payments got this amount. And if you clicked on Brock's slides yesterday, it actually takes you to kind of a 2 or 3 page fact sheet, and it does a quick math, and it says, well, gee, for instance, if in 2019, they didn't have the specific numbers for 2019, but if 2019, the total critical access hospital payment under Medicare was 14 billion, and if those same hospitals would have been paid 10 billion under the NAPPS and OPFPS program, then that difference, that delta of $4 million, gets divided by the total number of critical access hospitals, sorry for the typo, not DAHs, but CAHs, in 2019, of which there was 1,350. So that's where I think that maybe we're going to see a little bit of winners, losers, because if you just simply take 4 billion divided by 1,350, well, you'll see that some probably didn't have the volume to maybe get that amount before. So I'm not sure it's really an apples to apples comparison, but the process is just that simple and straightforward. We take that total delta, that difference between the critical access hospital payments and the inpatient OPPS and IPPS payments for 2019, and divide it by 1,350. And then each of these REH hospitals will get that amount. Now, again, we're going to need some refinement on that, because it's unlikely all 1,350 are going to convert. Plus, there's a large number of rural PPS hospitals that may want to move that direction. So we're going to need to see a little bit more here. But the thing that I think is important to understand is there's going to be a fixed amount, that facility payment. And again, just using the numbers that I saw from NRHA, it was roughly $2 million, a little over $2 million per facility. If you just divided that 4 billion by the 1,350, That becomes the facility payment for the new REH going forward, adjusted annually by a market basket percentage. So, once you get it, that's basically the amount you're going to have moving forward. So in some ways, I appreciate this view, this approach, because I think it's going to help our facilities and specifically our CFOs take a look at this and go, does this make sense or not from a financial perspective? Because if the last thing you want to do is, if you have a struggling critical access hospital or PPS facility, get into a no program where the numbers are even worse. So I think it's going to allow, I think this approach, once we get the data from CMS on what the total payments for in 2019 to the critical access hospitals were, plus what it would have been under the IPPS and OPPS program, I think that's going to give us some ability to do some modeling. Now, there are some issues with regards to this, and I think this gets to the point of also doing the numbers and doing the modeling on whether or not this would make sense if you wanted to do it. There's, I think, a real open question, and I'm thinking that the answer is probably going to be no, is whether the new rural emergency hospital will be eligible for 340B status. I think probably not. Or at least that's my concern. First of all, it's no longer, because it's no longer a critical access hospital, it's no longer going to be automatically eligible. And generally, it won't have the inpatient volume to meet the requisite 11.75 disproportionate share adjustment. So I think if your facility right now is relying heavily or really appreciates the revenue the 340B provides, I think likely that will not be there, absent some additional legislation that would include REHs, which would make sense, but they're, right now, they don't seem to be able to qualify for 340B. Next point, will REHs be covered by the FLEX program? Get that technical assistance and other support and that you currently get from the Michigan Center for Rural Health, will that still be available? I think that's an open question. There isn't anything specific in the statute that addresses it. I think it would be a natural to include it in the FLEX program, but it's an open question. Another open question, will the hospital's current provider-based RHCs be grandfathered in, remain grandfathered in? I would be concerned about that. Grandfathering generally is, well, you were there at the time, and so as long as you continue in that same status, you're going to be fine. But this is going to be a change in the status. And for those of you who've been around long enough and remember back from when your facility converted to a critical access hospital, you remember the whole process, and you actually get a new provider number. And so I would think that that would happen here. So I am worried that we would lose our grandfathered status for our RHCs. Hospitals that were caused, because obviously the PPSs don't have this, we're probably not going to be able, in fact, I'm almost sure we will not be able to maintain swing beds or continue method 2 billing. In fact, that one I'm almost certain on, because method 2 billing was specific and to critical access hospitals, and the new REHs have a brand new payment structure. So unless there is some action by CMS, because I think regulatory rulemaking, they may be able to make that happen. But I think it's likely that we'll lose the swing beds and the method 2. Now I say that under the Medicare program. It's also, the swing beds is also an issue under state licensing, because again, you got to be a licensed hospital to have swing beds. If we're no longer, or if we're a brand new category, under state law, our license may not allow us to continue that. So, if you have questions on this, please send them into the chat, and we'll get to them at the end of the program. I'm sorry, one more issue, and that is, under the statute, if you decide to convert to REH, you can always convert back. Now, it sounds easy. I do like the safety valve or the safety net of being able to convert back. But I mean, you're going to have to go through a survey and certification process when you go to REH. If you go back, you're going to have to do that again. At least I think so. I'm virtually certain. So we do have the ability to convert back, but I don't know that that's going to be necessarily an easy process. So 340B, I think there's a lot of good news on this front. I think it's still, it's not final because as Brock pointed out yesterday, excuse me, as Brock pointed out yesterday, we have a number of lawsuits filed by a number of pharmaceutical manufacturers that are challenging various aspects of the program. But we have a clear message on how HHS views this program and how they view the statute. And I think that's very important for a couple reasons. So two things happened here. Advisory opinion, this was late last year after our last conference, though, or early this year, 2021. There were drug manufacturers and covered entities both asked HHS for clarification on the contract pharmacy issue, because that's where a lot of the arguments happening. And it may be, quite frankly, what the reason drug manufacturers miscalculated on what this program was ultimately going to cost them. So HHS basically did issue an advisory opinion. So what an advisory opinion is from HHS is HHS looking at the statute in its own regulations and saying, this is how we interpret the statute. Now, that's critical because the courts tend to give some deference to the agency charged with interpreting and applying and implementing the statute. They give some deference to that agency and their interpretation. Clearly, when they're interpreting their own regs, they almost just uniformly defer to the agency's interpretation of the regs. But what I liked here was this language from HHS. HHS determined that the 340B statute could not be less ambiguous. So, I mean, that's part of the thing the drug manufacturers were saying. It's like, well, there's this question, right? This contract pharmacy thing, we never really envisioned this and the way it worked. We just envisioned this all running through the hospital's in-house pharmacy. And so they have taken the position that, gee, there's this open question. HHS has said, from our opinion, it's perfectly clear, right? Couldn't be less ambiguous. You're required to provide covered outpatient drugs at or below the ceiling price for drugs purchased by the covered entity. Crystal clear. And they added this requirement's not contingent on whether it's a contract or an in-house pharmacy. So it's great language with regards to this. They also determined that Congress clearly intended covered entities to use contract pharmacies. In fact, they went so far as to say that, if I'm remembering the percentage correctly, like only 5% of covered entities in rural and underserved areas have an in-house pharmacy. So if Congress intended, and it clearly did, to provide this for rural and other safety net providers, they had to have understood that we were going to use contract pharmacies. So again, HHS making it really clear, they think the statute's clear, this is what's required. So, and just leaving, or not, before we leave this, the advisory opinion also addressed their concerns regarding diversion and duplication. They said, gee, if they're concerned about that, the 340B statute has a process for resolving those concerns. And there's also this, because usually through the contract pharmacy process, there's a retrospective replenishment. And the manufacturers are saying, well, gee, this is a problem. And HHS said clearly, no, again, this is not a problem. So, and part of it was, gee, a specific package or shipment of drugs is a fungible commodity, right? And if you have this particular drug or pharmaceutical and it's in a box next to another one, which one gets used for the 340B program is less important. And so this whole concept about, gee, there's a problem with retrospective replenishment. Again, HHS has said clearly, we don't think there's a problem. So I think that's great news because it makes it clear their perspective. So that was back, I think, December or January of this year. Last month, beginning of May, we got a HRSA statement. And of course, HRSA is the one responsible under HHS for actually moving forward with this. But HRSA came out and said specifically that the drug manufacturer policies that place restrictions on the program are not permitted and are a direct violation of the 340B statute. So again, clear message. We have this advisory opinion from HHS. HRSA is going to take the position that what you're doing is a direct violation of the 340B statute, and to put the drug manufacturers in the statement on notice that if you're knowingly and intentionally charges a covered entity more than the ceiling, you're subject to the civil monetary penalty statute, not to exceed $5,000 for each instance of overcharge. Now, I love that language. I love it that the drug manufacturer is on the receiving end of that language, because it's like, not only are we going to have to, if they're charging us more than that ceiling, then they have to repay what we overpaid, plus every time they overcharged us, they got to pay $5,000. So if in one particular invoice, this is a little simplistic, but if one particular invoice, they overcharged us by $500, that invoice cost them $500 plus 5,000. The next invoice, the same thing. And so now some might say that, well, that's great, but what does that really mean? We have all these lawsuits out there where the drug manufacturers are challenging this. What it does is if HRSA starts leveling these fines under the civil monetary penalty statute, well, what they've done is up the ante, right? And it really becomes a question of, in the interim, over the years, because you figure that these cases are going to go to the district court, federal district court, they're going to go up to the various circuit courts, and I'm guessing that this may well ultimately end up in the Supreme Court. Well, that could be 3 to 5 years from now. And so what happens in the in-between, right? If in that 3 to 5 years, the drug manufacturers start going above the ceiling, well, then we all pay above the ceiling. And then, yes, back in the five years from now, if the Supreme Court rules in our favor, which I would feel pretty good about given the language of the statute, well, then we get our money back, and arguably with some interest. But in the in-between time, we've lost that revenue. By HRSA coming out and taking this perspective, what they've really done is up the ante and say, all right, well, understand, if you're going to charge above it, we're going to levy this penalty. Now, Can HRSA enforce the penalty in the in-between? Probably not. Probably the court's going to say, well, this is what the whole lawsuit is over. So you can assess your penalty, HRSA, but you can't collect on it yet until this case gets finally decided. But the consequence is now the drug manufacturers theoretically have more at risk, because if HRSA goes through and applies those penalties, well, then 3 to 5 years from now, in addition to having collected too much money and having to repay it, there's a $5,000 fine on each instance of the overcharge. Well, I think there may be some motivation then for the drug manufacturers to just stay with the ceiling until the litigation's over and then go from there. So some people have kind of poo-pooed a little bit the fact that we got this statement, kind of like, well, yeah, it's a lot of bark but no teeth. I think there's some potential leverage there that I think is very worthwhile. We'll see whether or not HRSA follows through. We'll see what the courts say. But I mean, with 340B, the news at this point is really, I think, going the right direction. In addition to that statement, if you go to the HRSA website and look at it, it's not a very long statement. It's just pretty straight and to the point. Yeah, you're violating it, and if you do, you're subject to civil monetary penalties. But HRSA also sent letters, and you can see the text of the letters on their website, sent letters to 6 major drug manufacturers saying, yeah, we think you're doing this wrong. You need to stop, or we may level penalties. All right, so Stark update. Oh my goodness, I'm looking at the time. I apologize. Stark update. We do have a number of changes, and I think here I want to just hit the highlights. Basically, under Stark, just about every one of our arrangements with our physician includes these 3 requirements. It's got to be fair market value, it's got to be commercially reasonable, and it cannot take into account the volume or value referrals or other business generated between the parties, just in all of them. So CMS has cleaned this up, I think, rather nicely. They've simplified the definition of fair market value. They've reaffirmed or confirmed that although the organization needs to maintain documentation on how it determined fair market value, there's a great deal of flexibility in what's required. It again confirmed that there's not a requirement that you get an outside, you're going to get an outside appraisal, but you do need to be doing it. I do think, however you do it, either your compliance people or the people who are responsible for the physician contracting should start with these slides and then obviously go to the regs. But there's this now general definition of fair market value. There's one specific for rental of equipment, rental of office space, which all include this general market value definition, which is broken up between assets and compensation. But it's really, I think it's really very, very provider friendly. I mean, it's one of those things. I mean, clearly, if you're trying to pay for referrals, you still got a problem. But if you're trying to comply, which I'm sure you all are, this really is a very provider-friendly change. There's also a change in commercial reasonableness. One of the issues that's always been out there, and I've talked with a number of you over the years, is this concept of, well, we hire a doctor, we know they're going to lose money, right? We're paying them, I'm just picking a number, $200,000 a year, and under their practice, they're only generating $150,000 a year, or their salary's $200,000, but with the overhead, the total practice expenses is $400,000. We're only bringing in $250,000. there's always been that question about whether it's commercially reasonable if you know you're going to lose money. CMS has made it clear that that is no longer or isn't a problem. They always take the position it's clarification. Would have been nice if it was that clear, 20 years ago, but it is a nice clarification there now. Their only concern, or what they highlighted as a continuing concern, is duplicative arrangements, and they specifically singled out medical director arrangements. You make somebody a medical director of a certain area, then you make somebody else also a medical director in that area. They're concerned there that you're not really paying for services actually rendered, but you're paying for, in essence, referrals to keep the doc around. Objective value test. I'll spend only a second on this. This is really good news. I mean, it's always been an issue, right? Cannot take into account the volume or value of referrals or other business generated between the parties. Well, gee, so when we decide whether to hire a doc, can we even think about what their surgeries are going to be like? And there's always been this very broad definition. The language was always there, takes into account volume or value of referrals or other business. So, but what did that mean? The way CMS under Stark had always done it before was to say, we're not changing that language, but we're doing little carve outs, right? So, if there's if you're paying on a per diem or per hour basis, we're not going to take that into consideration. That's not taking into account volume or value. CMS with this new approach has flipped it. So it's the arrangement only takes into account volume or value referrals if the formula includes the physician's referrals and there's a resulting increase or decrease, a positive or negative, a direct positive or negative correlation between referrals and other business and compensation. Or if you flipped it around and the remuneration was flowing the other way, if and it's the doctors are paying for some service, if the referrals go down, the charge goes up. So it's either that positive correlation or that negative correlation. If it meets that, then you got a problem. But if it doesn't, it does not take into account the volume or value of referrals. So important, such a big change. I want to skip through these. And then we have these new value-based, there's a totally new exception under value-based arrangements. There's 3 categories: full financial risk, value-based arrangements with downside risk, and then just value-based arrangements. I'm not going to have a chance to go into all of these, but I do have slides that cover it. That value-based arrangement is going to be very useful. In some ways now, most of you, if you're in a value-based arrangement, it's probably through an ACO, either in the MSSP or technically if you're in PGIP and you're in a physician group or a PO under PGIP, that's a value-based arrangement, and the PO is kind of functioning as an ACO or a clinically integrated network. It's pretty small, so it's just a PO. But I think we're going to see more of these types of arrangements. Specifically, we can say to our specialist, we can share some savings with you if we have these quality and cost metrics and you meet them. So I think it's really going to open up some opportunities for our hospitals and providers. I think that's just, I don't know that very many people have gone that way yet. And I think the tendency always is, bigger health systems do this stuff more than the rurals, but I think there's going to be some real opportunities, especially for specialists that are visiting, that come, 1 or 2 days a week or 1 or 2 days a month. I think there's some flexibility here, and for different value-based arrangements in those situations. So Sarah, I'm going to turn it back to you. I apologize for running over 4 minutes.
No problem. Thank you so much. We really appreciate it. So we do have a scheduled break until 10 o'clock, but I did see 3 questions come through our chat box. So Brian, if you want to hang out and answer those, we can do so.
Sure.
If folks need a break, please feel free to do that as well. So let me get those pulled up. So one of them is, many hospitals were forced to choose only one contract pharmacy. Does that mean that the charges for the other contract pharmacies is a violation? If yes, how do they report such?
All right, well, that probably gets into a little bit more detail than I'm sure I even have the expertise for. I'm happy to address the question, but let's do that offline because that one's a lot of detail.
All right, sounds good. The next 2 are around the REH designation. So can REH hospitals provide OB services?
That's a great question. And I think the answer would be, it's a great question. I think the answer would probably be yes. Clearly, if it was an emergency, somebody's having a baby and they go to the ED, they could do that. Could they do scheduled deliveries? And I don't want to show my clinical ignorance here, but I think the answer would probably be yes. That would probably be two aspects there, right? CMS is really concerned about access to OB services in rural areas. So I think CMS would be inclined to make that happen. They might be a little concerned and want to see documentation on how the new REH is going to be able to support that OB services if there was a problem with the delivery. That's a great question, but I think the answer is probably going to be yes.
Great, thank you. And I think our last question is, would REH be appropriate for a freestanding ED with ability for observation? It seems likely on the surface. Do you have any concerns?
No, actually, I think that would probably be the way to go. I mean, if you wanted to have a freestanding ED, I think this would be the way to go. Now, larger health systems are not going to be able to drop a new freestanding ED in a community because it has to be a conversion from a critical access hospital or a small PPS. But, getting to the point of where you may see some of these conversions happening, I wouldn't be surprised if some of the health systems in Michigan that have critical access hospitals don't convert their CAHs to an REH. In fact, I would almost guess that that's where we'll first see that happening.
Thank you again, Brian. We really appreciate you keeping us up to date, and it's wonderful to see you.
And again, I apologize for running over.
No problem. That's why we build in time in between sessions.
All right, thank you.
Thank you. We're now moving into a brief break until 10 o'clock. However, we will be opening the breakout rooms for you to join up until then. The next